I want to welcome everybody to a fourth session of AWE Week. It's a sixth annual interventional endoscopy course. This year topic is On the Road with Masters from US to Asia. And we have an exciting session plan for you. We have the three most authorities on the field, in the field of peroral endoscopic myotomy. We'll talk about every letters of the alphabet that comes before POEM today. And first, I thought, well, our goal today is to have a very informal discussion. So please free everybody to jump in and talk. But I think it would be good to start with us introducing ourselves. My name is Sonia Riker. I'm an interventional endoscopist at Harbor UCLA and co-founder of Association of Women Endoscopists. And I'll let Dr. Krinsky and Dr. Nguyen introduce themselves.
I'm Mary Lee Krinsky. I'm an interventional endoscopist at the University of California, San Diego. I am also one of the co-founders of AWE and delighted to be here for this session with some of our leaders from all over the world, Italy, Australia, and New York. This is fantastic. Welcome.
Yes, welcome. I'm Phoenix Nguyen. I'm a therapeutic endoscopist in Newport, California. And I'm also one of the co-founders of AWE, and thank you everyone for being here.
I'm Roberta Maselli from Italy, Milan. I'm part of the board of the WE, the Women in Endoscopy, and I'm also a therapeutic endoscopist.
Good morning, afternoon, and evening, everyone. My name's Payal Saxena. I'm an interventional endoscopist in Sydney, Australia. I'm at Royal Prince Alfred Hospital and Chris O'Brien Lifehouse.
It's wonderful to see you. Yes.
Welcome.
I think without further ado, we're going to start with Payal. Payal, you actually were one of the authors of a recent guidelines on POEM that came from SAGE. It's a very good read. Thank you for that. But I wanted to ask you about, sort of start with the pre-procedure assessment for patients who you're considering for ePOEM. Is there anybody who you actually would not, you would say, we're kind of sold that ePOEM is a good thing, but is there any patients in whom you would not consider ePOEM or would say Heller is a better option?
Yeah, so it's a very good question because often patients come with preconceived ideas of what procedure they want to have after they've received their diagnosis. And the literature suggests that in expert hands, POEM and helemyotomy are equivalent in patients with type 1 or 2 achalasia. However, in patients with type 3 achalasia or other spastic esophageal disorders, POEM is far superior. And the main reason is that in POEM, we can access the entire length of the esophagus, whereas with a helemyotomy, the surgeons can really only access the lower end of the esophagus. And in spastic esophageal disorders, the entire esophagus is affected. So in those patients, you should certainly be recommending POEM over a helemyotomy. However, if you're in a state or a city where you don't have a physician or a surgeon who performs POEM, or someone who's very early on in their learning curve, it may be beneficial for the patient to have a helemyotomy instead if they can see a surgeon who has very good experience, because we know from the studies that both are equivalent in patients with type 1 or 2 achalasia. Having said that, I think both surgeons and physicians perform POEM very well. The learning curve initially was quite steep, but I think now with wider spread use of the procedures, more proctors available, a lot of hands-on labs available at conferences and meetings, it's become easier and easier to train in doing these third space procedures. So it's very good for patients to offer these procedures, which are obviously less invasive than surgery, but achieve the same outcomes.
So with piggybacking on your point that you said that more people are now doing ePOEM and become more widespread, what do you think, what is important for sort of standardizing procedure, do you think functional luminal imaging probe like EndoFlip should be a standard of care?
I think devices like Flip are very useful in training and learning, particularly people who are early on or don't have a lot of experience or don't have the opportunities to have experienced proctors with them. So I think for those procedures, it's very useful. So for those who are unaware, functional luminal endoprobe is a device that you can pass into the esophagus during a procedure, and it measures the diameter of the esophagus or the gastroesophageal junction more specifically. And it's useful to learn in each stage of the procedure. When you're doing the initial submucosal dissection and then the myotomy, you will see the diameter expand throughout the procedure, which is what you're expecting. So I think it's a very good training tool, but not necessarily in long-term use. I think it's still in research phase and not necessarily mandatory for all people doing POEM procedures.
And Payal, can you comment then, we were talking about the differences between surgeons and gastroenterologists doing POEM. How about the long-term effect on quality of life? Do you have any comments regarding that in our patients?
I think I think no matter what myotomy the patient has, they have a significantly improved quality of life, which is a wonderful thing about this procedure. As endoscopists, I think this is one of the most rewarding procedure we can do for patients. They come to you without being able to eat, extraordinarily frustrated, and then a day after their procedure, they're feeling wonderful and can eat again. The good news is that in the long run, when this disease relapses, because we have to remember this is a relapsing remitting condition. We don't know why people get achalasia. We don't know why it relapses, but when it does relapse, we still have endoscopic options available to us, which is, I think, less daunting for patients. Surgery is a big deal. To have to go through a big operation, wounds, incisions, pain, post-procedure pain, and surgical complications can be quite morbid for patients, and endoscopy is much less invasive, lower risk profile. So it's reassuring for patients to know that should they need another procedure, they still have this minimally invasive option available to them. And I think it's quite reassuring for the community.
So during a procedure, if you have concerns about the future in terms of reflux, do you alter what you do and how you do the myotomy? Is your approach different to prevent the possibility of future reflux?
I think setting patient expectations is really important before you embark on the procedure itself. And I think in a broad sense, we all have to remember that the option of swallowing is going to be traded off with the option of reflux. And no matter what procedure you have done for your achalasia, there is a risk of some post-procedure reflux. And limiting your cardioesophageal myotomy may have some positive effects on reducing the reflux rates. And of course, we know now that there are many endoscopic options available as well for treating post-procedure reflux. There's even POEMF, so doing a fundoplication during the procedure itself is an option. So there are lots of options available. We do need to remember in the long term that majority of post-procedure reflux, and I mean greater than 90%, is treated quite easily with a PPI. So there is that reassurance that it's not too big a deal at the moment.
So post-procedure, would you go looking for esophagitis or Barrett's? Would you do an esophagogram or an endoscopy in follow-up?
Yeah, so I do gastroscopies in all patients after their POEM operation within 3 to 6 months. I don't have readily available access to pH testing at my unit, so it's not that easy to send patients for pH testing post-op. Otherwise, it would be a really great objective option as well. But I think in the long run, we have to remember these patients are at risk of squamous cell cancer of the esophagus, so they do need surveillance. And if there is any esophagitis post-procedure, that needs aggressive treatment and surveillance also to prevent Barrett's and Barrett's-related cancers. And we do know from the HeLa myotomy data that in the long run, over 30 years, there is a small percentage of patients who do get Barrett's and esophageal cancer as well. So I think we need to treat our POEM patients in the same fashion and aggressively survey and monitor these patients post-op as well.
That sounds great. Before we keep on going, Amrita, thank you so much for joining we sort of took a lazy way out, so we'll let you guys introduce yourselves. So please do, and then we'll keep on going.
Hi, everyone. I'm Amrita Sethi, Director of Interventional Endoscopy at Columbia University in New York, and have been a long time partner of these wonderful women who are doing an amazing job in California. And I'm sorry that I haven't been able to be with you all live past couple of times, but it's been really amazing to see how much work you've done in this field, and thank you for all of your work and including me in your series.
Oh, thank you for joining us. And please, guys, this is supposed to be a very informal discussion. It's always a little bit challenging on Zoom. Everybody worries they're going to interrupt anybody, but that, I think it's always okay. But we're going to direct some questions towards Roberta, but please jump in, everybody, with comments. Roberta, we thought about how can we find the most difficult topic to cover in 15 minutes, and we gave it to you because we know you can do it. So we want to talk about risk factors and sort of difficulties with endoscopic peroral myotomy. Is there something that could be done to lessen the potential complications, such as bleeding or perforation?
Yeah, some technical aspects. For example, if you think one of the adverse events or the complication you can have in POEM is, for example, the mucosotomy. So when you cut the mucosa from inside or from outside, and you create a full perforation, because later on you will do the myotomy, you will even cut the muscle. So it means that you have a full thickness hole and communication in between the lumen and the mediastinum. And we have some study, for example, showing that if you use a specific current, that is the spray coagulation, or a specific knife, this the TT knife, or even if you are at the beginning of your learning curve, you don't pay attention to try to dissect very close to the muscle, and you stay similar in ESD in the center or too close to the mucosa, you can have some trauma, direct trauma, or even injuries done by the electrocoagulation that is going there, and you can create mucosotomy and later on perforation. So there are small and typical aspects you have to take care by deciding the right knife and right devices you have to use, and then also how to use them, as a full knowledge of armamentarium, but also on how to use the things you have in your hands.
Is there any concern, like, are you concerned that with more and more centers picking up myotomy, it's achalasia is fairly rare disease. Are we going to have more and more centers doing one or two, which we really should not be doing, or how to overcome that?
So this is a wonderful question. The fact is that we don't have the answer, but we have some things to say. One is that maybe some years ago, we were not focused at all on achalasia. It was a rare disease, and just if it was jumping in your mind that that type of symptoms could lead to achalasia, you prescribe, all the tests available to make the real diagnosis. Nowadays, achalasia is, let me say, it's common from the diagnostic point of view. I mean, it's one of the first things when you have dysphagic patient in your outpatient clinic. So we have more tests to be done. For example, we were mentioning the endoflip before. The manometry, the HR manometry is very common. So nowadays is almost available everywhere in the world. And also the diagnosis jump to our mind all the time. So all these facts together, to me, make the in general motility disorder be more common than usual. So I don't know if the incidence that all of us knows is really the truth now. Maybe it's a little bit higher than what we think, even because we are not able. Yeah,
No, keep going.
No, I think
we are now
good.
able to
Go ahead.
Okay, we are unable to make also subgroup of patients. No, it's not only achalasia, but we have a full spectrum of different motility disorders. And this is why I think that the incidence is much higher than one would think. At the same time, if we make more diagnosis, it means that in time we'll have more patients to be treated, or they ask for a treatment, or they need a treatment. And I don't know if POEM is it the right way that all the center that have a therapeutic endoscopy is able to perform POEM is the way to go, that they perform POEM everywhere, because with the question to Payal, we were focusing, and I completely agree, on the follow-up. So you must be able to give the proper follow-up to all the patients. So it means that you must be a center focalized and focused on achalasia, and how to make the diagnosis, how to treat the patient, but mainly how to make the right follow-up to prevent the long-term adverse events. No, we were talking about reflux and even Barrett esophagus, and this is what I think.
I think the other aspect that's kind of interesting with POEM is that, you know, I have to say that I think the rollout of POEM has been one that is not necessarily encouraging people to just try one here and there. You know, we've really been, we're not teaching it as a standard thing in our advanced endoscopy fellowships. Not everyone is just, you know, trying steps to see if they like it or not. We're really kind of focusing on all of the training courses, you know, about a stepwise approach, whether it's ESD or POEM, but especially POEM, that requires access to hands-on, access to animal labs, access to preceptors, and like working closely with them. And I think, you know, from what I've seen some people who want to start to get into it, they start doing it and then kind of realize like, maybe that's not really what they want to do, because the time commitment in the training, as well as the commitment to dealing with the complications and whatnot, is just a little bit more than what they wanted, and they step away, as opposed to ERCP and EUS, which is so necessary in a lot of places that don't have access to it, that it's maybe justifies, you know, I learned it during my fellowship, I'm going to try it even if my volume isn't as high as it is. So I think the rollout, I think there's a lot of work to do on the training aspect and coming up with like our certification systems. And I think all of our societies around the world are trying to work on that, with consensus statements and that sort of thing. But in general, I think the average practicing physician is not just trying their hand at POEM. And I think that's a good thing.
That's a nice continuum, because we wanted to share a case with you that it's sort of a dilemma that always it is puzzling to us. Phoenix, did you want to do that?
The 60-year-old female, and she has chronic dysphagia, solids and liquids, and she has some chest pain, a little bit of heartburn. We did a Bravo study and an endoscopy. It looks like she has a Hill grade 3 and a 3 centimeter hiatal hernia. The picture doesn't quite reflect how big it is. And her Eckhart score was 7. If you can jump to the next slide for me. So we did the 24 the Bravo study, and was positive. Demeester was 21. On the next slide, you'll see our manometry study. And this was diagnosed as type 2 achalasia. On the last slide, we did also perform endoflip at the time of Bravo capsule placement, and very low distensibility, no peristalsis. So we thought this was a EGJ outlet obstruction. So we're wondering, is this GERD? Is this the hiatal hernia giving a pseudoachalasia picture? Is this achalasia and GERD? Which one came first? And how do we treat this?
Anybody? Solve all problems, please.
On the forward viewing endoscopy, was there any esophagitis or stricturing in the esophagus?
So that's a very good question. Thank you. No esophagitis, and you didn't have the usual pop that you do in a patient with achalasia.
And did you say there was a hiatal hernia? It looked like on retroflexion there was.
The patient has a Hill grade 3 and a 3 centimeter hiatal hernia.
Yeah.
It's difficult to say Yeah, seems there are quite two problems together. So
Is
let's
that
say if a patient like this come to
both?
me in my outpatient already with all the investigation done, and these are the reports, I would say to try to wait a bit and to repeat and to try to make a new visit in 6 months to understand really the symptoms, because do we know anything about the way this patient is eating? So this dysphagia is all the time, or when I don't remember if it's a man or a female, is eating very fast and is not chewing properly. So I make a lot of counseling with the patient about the way they should eat, and then try to understand if the symptoms are the same, if they have any reliefs from the modification of the habits.
Yeah, I agree. This is a very complex case. It's not really straightforward. If we go back to the forward viewing endoscopy photo, I think there may be a suggestion of perhaps even an early diverticulum developing in the distal esophagus, just as
It's like a
adjacent.
dilated, the esophagus was
Yeah.
dilated. The esophagus was
And,
definitely dilated.
yeah, and we see this in patients with achalasia, particularly the spastic esophageal disorders. Even post-POEM, they can get a redevelopment of their symptoms, which mimics their initial outflow obstruction, so to speak, but it can be due to food accumulating in a diverticulum as well. So the problem is not that the COJ is tight, it's just they've got other pockets where food accumulates and sits and causes the same sort of symptoms. And I wonder if there's a similar situation going on with this patient, and the solution is not really all that straightforward.
Yeah, I wonder too, if, you know, in most of our achalasia type 2 patients, they don't have hiatal hernias. And in this case, you may have an EJJ outflow obstruction with a hiatal hernia, which might be why you're experiencing reflux, but at the same time dysphagia. And I think an esophagram or a timed esophagram might be really helpful in helping to distinguish that in this case. Because if it is truly EJJ outflow, I would, you know, probably say treat that. This might be one of those cases where you do a trial with another type of intervention, whether it be Botox or balloon dilation, just to see what the dysphagia response is to intervention before going straight to POEM.
Well, thank God that you guys we're not the only ones having problem with this. So that at least makes us feel better. So in the last few minutes, we want to, obviously we would love to sit here and ask you 10 more million questions, but we want to be mindful of your guys' time. So just a few questions to Amrita, because we ask you to cover.
Wait, what happened with the patient?
Well, that's right. But we wanted to, for your talk, we were focusing on everything else other than esophagus. So to start with, GPOEM, who should we doing it for, and who should we not? That is the main question.
Well,
to be
I
or
don't.
not to be. What is your algorithm?
I definitely am not going to have those answers clear-cut answers for you. And actually, it goes. Maybe it's a good lead in this case, is that I think the farther away, or the more proximal and the more distally that you get from the lower esophageal sphincter and the classic indications for POEM with achalasia, 1, 2, and or 2, 3, and 1, the more difficult it becomes who to figure out to treat. Which are the ones that are going to respond, and I think they all respond less. So certainly that's the case with GPOEM. I think I think patients, there have been a couple of different ways to tell. We've had a practice here of doing a trial of Botox on these patients. It has to be patients who are not, where pain is not the predominant symptom, but rather nausea, vomiting, and early satiety. The diabetic patients don't necessarily respond as well. But in general, if we work very closely with our motility folks on these ones, absolutely not standalone, and they usually do try as much as possible a medication regimen, making sure that there are not other medications that are causing symptoms, and again, that pain medications are not coming into play. And then trial of Botox is usually what we do, or some type of pyloric intervention. And depending on who you work with, you can sort of work it out that you spare one area so that the G-POEM doesn't become as difficult. That does I found tend to be a good responder, although I don't think that's necessarily panned out in the data.
That is,
And then, of course, the EndoFlip is now a new tool, not necessarily proven to be beneficial, but I think, you know, Moeen's group did show that there is some value in seeing a response. I think there's a huge range of normal values, so that's what makes it very difficult to really understand what role that has in predicting who's going to respond. But there are some who respond really well, and that's great. And then there are some who are just not responders at all.
Gastroparesis is extraordinarily complex, and sometimes it's just a flip of the coin as to whether or not the patient's going to have a response.
Yeah.
We were going, you know, how on those shows they do a rapid fire questions. So we thought, since we have a limited amount of time, we'll do something like that for procedural questions. So for you guys, for G-POEM, is it greater or lesser curvature?
Greater.
Please don't say it depends.
It's greater, but it's greater for me, but I can do, I certainly can do both and have done both in the same patients.
Payal, Roberta?
Yeah, greater.
Okay.
Yeah, let me see greater.
Okay. That seems a transverse or vertical incision?
Transverse. For G-POEM?
Transverse.
Yeah, for G-POEM.
Transverse.
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 Oh, there is uniformity. Pyloromyotomy or together with some antral myotomy for G-POEM?
Pyloromyotomy.
Pyloromyotomy, sometimes a double.
Okay, that was my next question. Okay.
Just started it. Just
last small
Yeah,
entral.
okay. Some entral. Okay. And then full thickness or just circular muscle?
full
Circular.
thickness.
Which one?
You said together. I didn't understand your answer.
Yeah, you answered. Yes. Amrita, which one?
I said full
thickness?
thickness down to serosa.
Okay, Paya?
Circular. I'm very
Okay.
conservative.
Roberta, you have to break the tie.
No, in between, let me say so.
Yeah. And then finally, closure, clips or suturing?
Suture.
For me, it's clips. Clips are my favorite accessory in the world.
All right. Roberta, you got to break the tie again, right?
Clips, but if you have suturing.
Okay. So you're really not breaking
I'm in
it
Europe,
too
I'm in between.
yeah, exactly. You're really in between there. Just one or two questions more on Z-POEM. Where do you think, Amrita, is the place for Z-POEM in the practice? I know we touched on that in the practice on the average US interventionalist, because it seems could be a little bit more straightforward procedure, but on the other hand, in some places we don't see as much anchors. So
I mean, I think going back to what I was saying about POEM, if you're not doing POEM regularly, you shouldn't be doing Z-POEM. And the alternative of a septotomy is very feasible. It's not it's a safe procedure as well. We're still waiting for the data to really say whether there's a significant difference. And in some cases, you even prefer that if it's a really long septum. So I think that is a case where people should definitely stick with what they've been doing if they're not practicing POEM, and it should come as a POEM procedure that follows esophageal and gastric.
I see. What about STER? Where do you think that is a place? And any takeaways from DDW we just came from? Where is that place for all of you, you think?
I
Because
think
it seems. Go ahead.
I think STER is one of the really wonderful offshoots of the POEM procedure. that's been developed, because these patients avoid major mediastinal surgery as a result. And so if you've got a lesion which is not malignant, and you can remove it en bloc for GISTs, or even piecemeal for lyomas to remove them from the incision and the tunnel, it's a wonderful outcome for these patients avoiding major surgery. I think apart from regular POM, this is the second most utilized and useful procedure that we have.
What do you guys think?
I think especially for those at, you know, GE junction or right in the cardio, where the alternative of having like a gastrectomy or esophagectomy is definitely much more morbid than the problem. I think one area where we may need to be careful is, you know, lesions that is really understanding how exophytic the lesion is, and lesions that are truly more on the serosal surface. And, you know, if there's a risk that you invade the capsule and you kind of get into the peritoneum, or you even lose the lesion, I think that's something to think about. And a surgical version, like a wedge in the stomach, is not a bad procedure. And so I think we have to make sure we work with our multidisciplinary teams and really knowing which are the best lesions to go for.
Yeah, one of our upper GI surgeons, who's also an endoscopist, actually operates next door to me on a Tuesday, and we've done some of these combined. So like you said, when they're really low down, just at the COJ, I tunnel the lesion, push it down into the stomach, and then the surgeon does a small wedge and removes it within a few minutes, which is so much nicer and easier for everyone involved than spending hours and hours trying to pull this thing out of a tunnel.
Yeah.
And just as a final, Roberta, what are you going to say?
I know,
Something,
I
please?
completely agree with too, but the only things I want to say is that stir is not easy at all. I mean, sometimes it can be very easy. Like, for example, if you have small tumor, subepithelial tumor in the junction or over the junction. So in that case, it's quite easy. But in the stomach, for example, as Amrita was saying, if it's inviting this serosa or it's deep in the muscle, it can be very challenging, because even the device we have right now, they are not made for this. We are missing the traction. So sometimes to work together with a surgeon is much easier. So take care of, make the right indication for this patient. Otherwise, we can make disaster.
That is a very good way to finish, I think. But with the last question, kind of a parting thoughts, do you think it's a place for a surgeon to perform these procedures, or is it for us, for the GI? Where is it ours, or does it have to be either or? Maybe it doesn't.
Yeah, I think if you look at the initial in the initial groups who started doing POEM back in 2010 to 2012, it was a mixture of surgeons and gastroenterologists. And at the end of the day, the person who should be performing these third space procedures is someone who has a very good technical skill set for endoscopy, as well as a good understanding of the tissue planes and layers. And it can be either a surgeon or a gastroenterologist.
Yeah, I think the field of endosurgery is being defined, and it's definitely going to involve both sides. There's no reason not to. I think the skill set, that the handling of the scope and the knowledge of the instruments and the currents and the endoscopic view of the planes is invaluable, as is an external view. And, you know, I think whatever training system we come up with will probably also need to involve us really looking from both sides, everyone looking from both sides to understand what we're doing.
Roberta?
Yeah, completely agree. I cannot add any more. I do believe exactly the same.
Well, on that positive note, I think we're going to thank you all for coming, and at early hour, late hour, middle of the day. Thank you so much to all of you. And we can stop the recording.
Thank you.
Thank
Thank you so much.